Good afternoon. I'm Bill Pugin. I'm actually from Marshall University, previously from the U.S. Senate. I'm pleased to be here today to be able to moderate this session. Health data, a bone of contention between researchers and patients. I have been pleased to be able to have the perspective of both, I suppose, patient, researcher, and also having to be one of those individuals working on the policies that govern both of those. I want to take just a few minutes to kind of introduce the topic here and then go on to our panelists. The bone of contention that we're talking about, I think, has to recognize that they're both convergent and divergent interests between patients or individuals, as we were talking about in the last session, and researchers. We have a common interest to improve health. We have a common interest to ensure the affordability and the accessibility and the sustainability of health care. On the other side, we all both recognize, from whatever role we're in, that data is an essential part of moving research forward and improving health care. There's some distinctions here, and coming from the research community, spending most of my career there, I think it's important to recognize that I have, as a researcher, somewhat different professional and financial interests than a patient does. I think that's an important thing. We do project the ideals or the nobility that we're trying to do research to improve public health. In recent years, we talk a lot about some modifications sometimes of ethics, some modifications of access to data in order to serve the public good. To me, I think that does imply some certainty that we're going to get a good result and that all research is going to be productive in some way. So there's some conflict there, I think. Where is the public? And most of you are familiar with these statistics in terms of treatment, payment, exceptions for healthcare operations. When you survey the public, most patients that you run into will say they are in favor of their physicians having access to data, of the payer having some limited access in order to pay, but sometimes not in detail. But when we get to research, 3 out of 4 individuals would entrust all their data with their primary care provider. When we get into other kinds of practitioners or research, we get very different numbers. Going back, I think this is the old IOM numbers. 1 out of 5 individuals would actually be okay with their data being accessed without being consented by an IRB. And only 10% actually placed great confidence in researchers to directly access that information without consent. This comes from a Jamia article from 2012. I think it's notable when you look at the chart here in terms of access to sensitive and less sensitive data. Over here in the far right, we as researchers come out near the bottom of the heap in terms of people's willingness to give us a carte blanche access to their data. I had the unique opportunity, and I'll say opportunity, to be a part of the health or the high-tech bill, actually working on that from 2004 or 5 right through the stimulus to get that done. That was our idea of a breakthrough bill that would improve the flow of data, improve access to data, improve care. As we're standing today, I think I've had the opportunity the last 2 years to go back into clinical medicine and work in a family medicine department, and people want to throw stones at me over that bill. We don't have the interoperability that I heard Senator Bill Frist promise in 2005 would only take a year. We certainly don't have the security. I was involved in that breach provision, and the health outcomes improvements are yet to be realized. So and then you add on to that sustainability. We pumped a lot of money into doing a better IT infrastructure, and we still have a long way to go there. Today we're going to hear about some possible solutions. 2 of our panelists here have been working in efforts in the EU, and another here on another model in the United States. And I think it's a good opportunity to learn what might work and what kind of solutions we have on the horizon. What I wanted to set up, rather than throwing questions out at the end, I wanted to throw a few questions out to have us all think about at the beginning. And hopefully at the end we'll have enough time that all of you can kind of chime in a little bit too. I think that in terms of the systems that we're looking at, we need to answer some questions. Who owns data? Who controls data? within each of these proposals in terms of getting at both the clinical and the research data and building the connections we need to improve healthcare. Is consent required? If the issue is the inconvenience of consent, do we have another consent model that might work better? What's the security standard? As an NIH researcher and clinical researcher, I'm very familiar now with the changes in terms of de-identification and needing now a consent for that data on NIH grants. And what model that we have, what model we may talk about today is the most practical in terms of working for the patients, and is the model that we're going to talk about, or is any model, what does it take to make that fiscally sustainable? So without further ado, I want to step forward and go ahead to the panelists here. Magdalena Goralczyk is a senior research associate at the Institute for Legal Informatics at Leipzig Universität Hanover, where she's engaged in addressing patient and researcher interests, specifically consent and sharing, and she'll be talking a little bit about the EURECA project. I'm going to have her speak together. I'll have her start, and then Alan, I'd like you to join in with her. Alan Dahlke is at the same institution. His subject is patients as data subjects in Europe. He's going to be talking about the MyHealthAvatar project. Alan studied law in the U.S., New Zealand, and Germany, so you have a perspective on different systems, certainly, and he's been advising on data protection for EU projects. So, Magdalena, I'll let you start, and then Alan, perhaps you can follow.
So firstly, thank you very much for being here. I will be speaking, as Bill said, a little bit about the EURECA project. Firstly, we'll need to solve the technical issues. And before maybe I get my slides, I'll just start. So what I will do, I'll mostly focus on legal solutions in Europe to give you the background there, and then I'll jump into the EURECA project to give you a very, very short introduction into what were our lessons learned in those projects. I see that my formatting got corrupted. That's the typical Mac versus PC issue, but I hope this won't really disturb us too much. So just to understand, to let you understand where I come from, as I said, Germany, Leibniz University, and what we do in Europe, as it's rather complex there, we have the European Union and then member states of the European Union, which is something less than federal states here. And the European Union supports a lot collaborative research throughout the European Union. And so they give something probably a similar financing like you maybe get into Coronet, some money to try to bring together different countries in the European Union to do research together. And our institute, which is the Institute for Legal Informatics, which is one of the oldest entities in Germany who does law and IT, is heavily involved in medical research, where we try to advise mainly physicians, researchers, but also IT people on ethical and legally compliant research. And I'll now try to explain you like the very basic differences between US and European approach. But I'll start with going back to the roots, because I think it's a very, very interesting thing is to understand that both EU and US come very much from the very same beginning. Somewhere in the 70s, across the Atlantic, both in US and in UK, there was some basic research done on what the computers can and cannot do and how should they do this ethically. And there were reports of the Committee on Privacy in 1972 by Kenneth Younger, which was done on behalf of the Queen, and here on behalf of the Secretary of the Department of Health, another report, both based on Alan Weston's Privacy and Freedom very much, and they really found the very same thing, that there is a set of principles which are very, very basic, and which secure that individual, who is then the patient or the consumer of healthcare, however you call him, has their rights safeguarded. And this is very much the fair and lawful processing. This is the purpose limitation, who says, okay, if you collected my data for one thing, you should not just use it for another. The data quality, the data is adequate, the data is actually limited, so that we don't collect all we can, but we collect only as much as we really need. All of those things are still there in the core of many of the systems on privacy and data protection, but I think today they get very, very much forgotten. And if we compare the law applicable in the US and EU, a couple of things are very, very visible. So as far as I understand, and please correct me if I'm wrong, there is no one legal act which would apply to any personal data or personally identifiable information in the US. This is completely different in European Union. There's something which is called the Data Protection Directive, which is under review today, but it still takes time. And the Data Protection Directive, actually, despite it has to be transposed into each of the 28 member states, brings some common level of protection to each of them. And what it also does is it applies not only in every member state, it applies to any personal data. So we have a very wide definition of personal data, and automatically, it doesn't matter whether it's a hospital or a Fitbit company, automatically we apply our data protection standards to that company because they are processing individuals' personal data. And I think this is something which shows a completely different approach between the two continents. And I'll try to go a little bit stronger into that direction, and I'll leave US aside because I think I could learn much more from you than you from me in that subject. And I'll just show you how wide the definition of personal data is. It is any information related to an identified or identifiable natural person. And the important thing is the identifiable natural person, because it basically means any person which can be singled out, meaning it doesn't really matter whether there's an ID number or your phone number or anything else for getting in the name. It just means you're singled out, meaning that any data string which leads just to one person is actually personal data. And this is really the crucial part of the personal data definition, because this is something which makes any data which is concerned with an individual actually falling under the data protection provisions. And what we also have is we don't have any specific legal acts on health data, but we have more strict rules in the Data Protection Directive with regards to so-called sensitive data. And you can see that this is all things which could be causing discrimination. One of the things which is there in blue is data concerning health. And what you also see in the Article 8, which I'm just brought in here, member states shall prohibit the processing of data, of sensitive data, data concerning health. This means that basically, as a rule, processing of personal data sensitive personal data in Europe is prohibited. So it's absolutely illegal. This sounds, of course, like something which cannot be, because, of course, also in Europe we have healthcare records, etc., etc., etc. However, the basic rule is put differently. Give me a good reason why you process, and I allow your processing. And I gave here, in a very, very big simplification, the 4 legal grounds which can apply. So there are 3 typical legal grounds: consent, care exemption, and national research exemption. And there's something else which I'll explain in a second, which is anonymization. Let's start with consent. What consent does, it requires, of course, prior agreement of the data subject, so the individual. The problem here, it has to be informed, freely given, specific, explicit. And I think we come very much to what you said before: is consent the right vehicle? We have huge problems also in Europe in obtaining consent, which would be on the one hand valid, because it would be, the person understands, the person is informed. On the other hand, useful, because we often have physicians coming back and saying, well, I have some consent, but I don't really know whether we can start anything with it because my new research proposal doesn't really encompass this. So this is the first problem which we have with consent. The second thing which happens is the care exemption. We can, of course, process data for care, but here comes the purpose limitation. If you use data for care purpose, you have to be limited to treatment, to care management. This means that you can't simply say, well, it would be also useful for the employer, so let's just send this data out. Just something which was spoken about before was something which deeply scared me, honestly speaking, because I didn't know that this can happen. The third thing, which is something which is very debatable in Europe, this is the so-called national research exemption, which allows using the data collected for other purposes for research. The problem there is no unified standard throughout Europe. Member states have segmented regulation on this. Generally, what is important there, you always need specific safeguards. You're not allowed to just simply use the data. Somehow you always need, and this is different in many member states, but you need ethics approval, you need a specific process of how this data is being used. Finally, there's something which doesn't really belong to those four categories. This is anonymization, and this is, of course, not a legal ground, but as I said, there is a very wide definition of personal data. What doesn't belong as personal data falls outside of the scope of directive and can be processed freely. Our problem there is, of course, the data can no longer be associated with a specific individual. Is this at all possible today with health data? We believe, at least in the Institute, and this is also my personal belief, because I also wrote a PhD in anonymity, that this is a very convenient fiction, that people agree, okay, let's treat this data as anonymous, and then let's do whatever we want. Because this kind of takes away all the burdens of the Data Protection Directive in Europe, supposedly also here of, let's say, HIPAA, because you just simply say, well, now we treat this data as it cannot be connected to a person, so we just play with it as we want. And now let me get to EURECA. EURECA is, as I mentioned already, a project sponsored by the European Union, the European Commission, and what we try to do there is enabling information reuse by linking clinical research and care. So the very same problems which Bill already mentioned, semantic interoperability. We try to have the domains of care and research connect more so that we can reuse the data, we can have this wonderful and spoken about bench-to-bedside approach in which we would like to have, of course, patient benefit from research faster than they do now, but we have the problem that the domains don't speak with each other because you have different standards, all of what you probably also know from US. And of course we have lots of people like data miners, physicians who want to do wonderful things, and us standing there simply saying, no way, this is so, so bad, and they all hate us. So I imagine that maybe some of you share that experience, but the project is ending, we have some lessons learned, and what we also have is this idea, okay, what the project wanted to do. So we have the researcher, and the researcher would like to, for example, as one of the scenarios which we could use here, know, okay, will I find patients for my new research hypothesis? So let's say I want to research, people who are 50 and have diabetes and take this kind of drugs and move little. Can I ask every single clinic with which I am associated, will I find patients if I just put my idea, let's say 50 to 55, diabetes, BMI, so-and-so, or do I need a wider criteria? And the idea here is, that he should access the clinic directly so that he can fix his research hypothesis. As you imagine, many things can go wrong there, and our main role here was to try and to bring some sort of balance between his right and the rights of the data subject there. Similarly, the doctor would ask another question, okay, can I faster know which of my patients would fit to which clinical trial? And I think the idea of this arrow is exactly that those two domains speak faster, but as you see, I put those brackets around them exactly to ask, okay, does patient have to be outside of those brackets? Does he have to ask, so I have no idea what's going on with my data. And our idea here was that, what we kind of forced through to the researchers and to the IT specialists that, okay, for example, if the researchers want to ask such questions, it's fine, it's perfect. We all want this to move on. We want those research proposals to be more successful because one of the problems which we have in Europe is a very low enrollment rate. Many clinical trials in Europe actually fail because then they don't find patients. So we want, of course, this to succeed, but what we want is for them to only work with aggregated data so that the researcher gets actually an answer saying, yes, you'll find enough patients, we will have, 100 of those. But what we still want that even if only aggregated data is actually being sent out, we still want that if the data is crawled, it is only when patients agree on that. And this is for two reasons. For one, of course, because the idea is that the data is, belong to the patient. We want it to be acknowledged. But the second one is also, why should the researcher be interested in patients who don't want to participate anyway? Because you don't want to know, okay, we would have, 200 patients if 100 of them will not participate in a clinical trial. I think I'm running late, so similarly, again, patient involvement with the physician, but I'll end up here, and I'll give the floor to Alan. I hope Alan will speak a bit more about consent and different things, but I'll just mention two things, the two things which we learned in EURECA project, for me, the most important ones. For one, that we really need a reform of consent, which would allow more granularity, because this will give us the possibility to really follow patient wishes in a more direct way. But for this thing to work, we need two things. For one, we need less strict requirements to consent, because if we want to have a very, very specific consent questions, that we cannot really achieve proper answers because the patient gets overburdened. And for the second, we need technology. We really need technology to kind of save and give further as authorization all of the wishes of the patient, which is very, very hard, not to say impossible today. Okay, so, and could we go? Yes, okay. Perfect.
Okay.
Oh, yeah.
Great, thanks. So, yes, I'll be talking more on consent. My talk is on the MyHealthAvatar project and patients as a data subject in Europe. And here particularly as seen through the lens of two issues. The one is the patient-researcher relationship, and the second is basically broken healthcare systems, a problem which I think most of Western countries face. So, if we look at the patient-researcher relationship, at the core of this is, of course, the patient. Patients are the source of research data, and generally patients also do want to benefit from research. However, as Bill also explained, today patients are a little bit wary of providing their data to researchers, and researchers here as distinct from the primary care physician. Now, in the past, the patient-research relationship was one very much marked by clarity and by trust. It was also a rather personal relationship, perhaps even intimate to some extent. Today, however, frequently, technology has upended the balance. The relationship is no longer as personal as it used to be, and research is also conducted on a much larger scale, and the potential impact of sharing one's data is now a lot harder to predict. Smaller, localized studies, perhaps using pen and paper, if one wants to think a little bit anachronic terms, are in part being replaced with digital number crunching. Now, data analytics and data portability mean outcomes from data might be produced that the patient did not even fathom in the beginning. So this was the one backdrop. The other one, broken healthcare systems. Now, aging populations are putting financial constraints on the European welfare state. Now, as in other sectors of the economy, ICT is hailed as a savior that will increase efficiency and hopefully unleash a revolution in healthcare. And the previous talk by Sandy also pointed us in the right direction. Precision medicine is a term which is frequently being used. However, ICT for health is lagging about 10 years behind other sectors. Now, the reasons for this are manifold. The complexity of medicine, simply the care of medical care, surely plays a role. However, another huge problem, simply missing standards and also data siloing. So Magdalena's project, EURECA, is an excellent example in that respect of efforts to achieve semantic interoperability between the clinical domain and the care domain. Now, a further problem, and as lawyers, one which we're very interested in, is simply the law. Now, data is frequently legally inaccessible to researchers. Now, against this backdrop, MyHealthAvatar says, okay, this is the background. What are we going to do? How can we fix this? Well, one is by taking a patient or an individual, a person-centered approach. And the idea here is to empower patients and increase patient autonomy through the use of digital avatars. Now, digital avatars are basically personal health records. A colleague of ours called them PHRs Plus, a 2.0 version of PHRs. They are supposed to facilitate the long-term collection and logging of medical and lifestyle data, and they should also be a part of a larger networked ecosystem that is open to third parties through APIs. Now, digital avatars address a couple of issues that traditional PHRs have, and which might be a reason why traditional PHRs haven't really taken off. So by making data nicely graphical, by just interpreting data in a nice user-friendly way, the idea is that data, or that users will have more emotional involvement. They'll become more emotionally engaged in their data. Now, I'm not talking about their data in a legal sense. I'm talking more in a legal sense, in an ethical sense, because ethically, it is their data. It comes from them. They're the source. So what I mean about having patients engaged is more that they want to take active control of that data. If we look at social media, we see that people are very, very, very happy to share nicely interpreted lifestyle data. How many steps did I take today? What's my heart rate after climbing the 10 floors in my office building? And so patients are not always, reluctant and saying, no, I want to keep my privacy to myself. However, when it comes to hard medical data, hormone values, radiology images, and so forth, patients, I believe, feel somewhat disattached with the data. They don't have this personal relationship to it. They don't know how to interpret it. It's abstract. It's just numbers. So in MyHealthAvatar, coupling this with a framework of consent where the patient also feels actual ownership of the data, the hope is that patients will be more likely to grant consent for research. And this is where we come to the law. Now, as Magdalena already said, in Europe there's a general prohibition on the processing of so-called special categories of data, such as health data. Now, consent is one of the exemptions, and consent must be voluntary, explicit, informed, and specific. Now, the first two are rather clear, so I'll skip those, and we'll talk about specific consent. Specific means exactly that. Now, a general, broad type of consent, for example, I'm consenting for cancer research, is insufficient in Europe. And consequently, giving consent for any type of future research that is not yet fully laid out, fully detailed, is impossible. You simply cannot do that. It's not specific enough. So that's a huge issue. Another problem is how informed consent must be. Now, informed consent in Europe requires that the patient or the data subject fully appreciates and understands all facts and also all the implications of the processing the patient is supposed to consent to. As a consequence, the patient must be provided with full information on all issues, such as the type of data, the purposes of the processing, who's going to get the data. That means that the patient will also have to read a lot. Now, in MyHealthAvatar, the idea is to introduce something called granular consent. We'll have we'll have a finely grained choice which the patient or the user can consent to per individual processing act. Now, this will require, of course, transparency on the processing, and that MyHealthAvatar focuses on providing all required facts to the patient in an easily understandable and appropriate manner. Now, alas, the idea behind that is okay, but in fact it's not really that easy. Getting a patient to truly understand the implications and the facts of a processing act as required under European law is very, very difficult. A patient who has to scroll through pages and pages of text will likely not be truly informed because I think we've all gone through the same process with software terms of service. We just look for the checkbox, click it, and click next. We biked here today using the wonderful DC biking system, and you also have to consent there. 131 pages, which you're supposed to read. I would like to know how many people have done that. We certainly didn't. Consent theory sounds good. One can technically implement it, but it certainly isn't, a proper solution. might we need to reform consent? Well, as Magdalena already mentioned, the European Data Protection Framework is currently being reworked. The final outcome of the new proposed EU General Data Protection Regulation is not yet final, but just, I think, 2 weeks ago, the Council of the European Union issued a new proposal. And one of the very interesting parts is that now it seems, okay, we will be at least adopting a sort of broad consent, sectorally speaking. So I've highlighted the important bit in bold. Data subjects can give their consent to certain areas of scientific research when in keeping with recognized ethical standards. So what might that be? Well, we could have, for example, if an ethics advisory board says, okay, here giving broad consent for a certain type of cancer research, even if the exact research project isn't delineated, that's okay. And that would, of course, greatly facilitate future endeavors. So that was it. Thank you.
Okay, next will be Dr. Bill Yasnoff. He comes to us with a very unique background. There aren't too many individuals with a PhD in computer science and an MD working in our field, and that's a unique combination. His works included pioneering work in informatics at Oregon and at CDC. He authored over 250 publications and key health informatics textbooks. He led the effort to establish a national coordinator for HIT, and he's founder and managing partner of NHII Advisors. Bill's recently confronted some very critical issues concerning data sampling and aggregation, and he's been focusing on utilization of a health bank model. If you can just put your laptop up there. No, behind you, on the panel. That'll come right on. Go.
There we go. Great. Thank you very much. So I'm going to talk with you very briefly about an important security issue in patient health record repositories. So I'm going to give a very brief overview of health information infrastructure and the key challenges, and thankfully Sandy Pentland covered much of this in his talk, and then talk to you about this new approach to securing records in a health record repository. So the goal, in my view, of health information infrastructure is to have comprehensive electronic patient information when and where needed. And it's a simple statement, but it's complex to do, and you need at least two components. First of all, you need EHR, so all the information is electronic, and then you need some kind of health information exchange mechanism for finding and aggregating and delivering comprehensive records for each person. So there are a number of challenges to meet this goal. First, as I said, the records have to be digital. You need the stakeholders to cooperate. You need financial sustainability, which Bill already mentioned. And you need public trust. And of course, the security of the records fall into the domain of public trust. Very briefly, our current health information infrastructure efforts not only don't work, but they can't work. And what we're trying to do is we're taking the wrong approach, trying to replicate the manual process of contacting other providers directly for records. So today, if you go to your doctor's office, you have records elsewhere, they call, have them faxed over, and so the idea is to have a button you push and have that done electronically. The problem is this doesn't work. It's very expensive, unreliable. All the EHRs have to be online 24/7 to respond to queries. You have to reconcile multiple records in real time. It requires a unique patient identifier, which isn't going to happen in this country and is also a huge threat to privacy. And you also need an expensive 24/7 operations, network operations center to monitor all the EHRs to make sure they're online. So the solution to this problem that I've been advocating for many, many years, and I don't have time to go through all the details, but I'll give you an overview. Again, reference what Sandy Pentland said in the last talk, is essentially it's the model that he presented, except I'm advocating that in each community there need to be one or more repositories for records, that you can't leave the records where they are. That just doesn't work in healthcare. And the access to the records needs to be controlled by patients or whoever they designate. Think of this as electronic safe deposit boxes. And information about care is deposited once and only once after it's created, which is required by HIPAA. And this model allows you to provide EHR incentives to physicians that helps you make the outpatient records electronic, and it's very simple and inexpensive. And I have a short video that explains it.
Imagine you or someone you care for is rushed to the emergency room and might even be unconscious. Without important medical history, lives may be in danger. Does the emergency room doctor have all of your up-to-date personal health information? Do you? How can you or your doctor get it immediately? If you're like most people, your medical records aren't readily available to you or any doctor. Today, wherever you seek care, a record is left behind. A record you and your other doctors can't immediately access. Until now, no institution has been available to automatically receive and securely store your records and make them easily available when and where you need them. Now there's a way with health record banks, a secure approach to storage where you alone control access to your health information. Think of it like a digital safe deposit box. When seeking care or in an emergency, you authorize an information withdrawal, giving your doctor access to some or all of your records. When care is complete, new records are deposited, and the information can be used to automatically complete time-consuming forms. Health record banks make good sense. You alone control who accesses your personal, private health records. Records are stored in one location and automatically updated when you receive care, anywhere in the world. Your information is safeguarded by the most secure data protection and encryption methods. And with multiple banks available, the choice is yours. Take control of your health records today. This message brought to you by the nonprofit Health Record Banking Alliance, promoting and supporting the development of health record banks.
So the architecture for a health record bank is very simple. Your records are in an account under your control. When you see a clinician, the clinician requests the records. Those that you've decided can be released, presumably all of them to your clinician, are released. The encounter occurs, the new records are deposited. The rationale for this is operationally it's very simple. Your records are immediately available. New records are deposited when created. It enables value-added services because you have the records in one place and you can work on them. It enables research queries, of course, with consent. Patient control promotes trust and privacy, and the patient control also forces stakeholder cooperation in the U.S. under HIPAA. The low cost of this facilitates a variety of business models, and I'm happy to talk about those, but this can be done in a way that is definitely sustainable, actually quite profitable, and you can use the revenue generated to create EHR incentive options to either pay physicians for deposits of records or provide them with no-cost internet-accessible EHRs. However, there's a very important security challenge in health record banks, and that's what I wanted to specifically address. It's well known, and this is, you'll see this is an old reference back to 1976, but this is so well known it's not really challenged, although I guess Sandy doesn't agree with this, that centralized data is the best way to ensure security. Distributed data is less secure, it has to be transmitted multiple times for each use. But there's an inherent vulnerability of a central database, and we all know about this, which is that you have this single point for access to all the data. And so potentially, with a single unauthorized intrusion, you could lose all the data in a single incident. And no matter how low the probability of that is, the fact is it is a problem. People worry about it. And we all know about the multiple security breaches that have occurred. They're in the news. Anthem has been picked on, but there's also Primera and Care First Blue Cross in this area. And so most people believe that no data is secure. I don't agree with that as a computer scientist, but that perception, I think, is now reality. And so the issue is how can you have efficient searching without a central database? And so I'm going to show you how. So if you want to avoid total data loss, instead of having a database where you have all the data in one file with an inverted index, you can store each patient's record in essentially a separate database or a separate file, separately encrypted, with a different key. Every patient has a different key. And so the advantage of this is there is now no place where you can actually access all the data. In fact, if someone were to physically take the server, they would have to break through strong encryption to get one record. And then they'd have to break through different strong encryption to get one more record. And so they just don't get all the data. Plus, no one who is actually operating this system has access to more than one record at a time. So that's great. No single point of access to the data. The problem is now, if you want to search this data, you don't have an index anymore. So you have to search it one record at a time. So you have to get record 1, decrypt it, look at it, and get record 2, decrypt it, and look at it. And we in computer science don't do sequential searching because we like our searches to finish before we die. So how do you deal with this? Well, it turns out that, and here's the essentially the algorithm for searching these separate records. You have to retrieve one, decrypt it, search it, go to the next one, and you're done. And this requires for n records you have to have n operations. Well, what if we have 2 processors? Well, interesting. So now we can retrieve 2 records at a time, decrypt them in parallel, search them in parallel, and then go back. And when we're done, now we have half the number of operations. And you can guess where I'm going with this. What if we have k processors, some arbitrary large number of processors? You can do a lot of searching in parallel. And now you have n over k operations before you're done. And today, in the cloud, you can requisition 1,000 or even 10,000 processors and get pretty good response times. And it's not costly at all. So I call this the personal grid architecture, where each patient's record is stored in a separate database with separate encryption, using efficient, massively parallel searching, using virtual processors in the cloud or in a network, and so the data could be on your mobile phone and could be searched there. You can have good response time, but there's no access point for all patients' data, even for the operator of the service, and so it eliminates completely this database in the sky security vulnerability. Thanks very much.
Good. Questions?
We got
I think you were the first responder.
Yeah, I guess officially.
Go ahead.
Happy to follow your lead, whatever you'd like. Thank you. So, very interesting, stimulating presentation. I think taking away different things from all three talks. I had a few questions, I guess, that are maybe a little bit more general, but if you could speak to one or two of them, it would be wonderful. I think sort of things that I've been reflecting on while listening to your talk. So one thing that comes to mind is this idea of patients and individuals who have access to their own data and want to share it. And in some systems in the U.S. and possibly in other countries, we have systems in place, oversight systems, that make that quite difficult. And whether it's sort of sharing it with researchers or sharing it with platforms where the data can then be accessed by a number of different people. So there's some amount of interest. And I guess my question is it a problem to establish an oversight system that blocks that kind of activity, sort of community-generated, community-oriented research? Do we see that system in the EU? Is it comparable to what we see in the U.S.? That's sort of my first question. My second question is sort of speaks to, I think, the idea that you raised at the beginning is consent the right vehicle for patients and for people who have ownership of data. So there's been some sort of recent movement towards e-consent models and things like that. And I would love to hear your perspective from the EU perspective and the US, sort of what are the barriers to using e-consent? And do you think e-consent is a viable option here? And Or is it really we just need to get rid of consent and do something totally different? And then I suppose the last question has to do with it's more of, I guess, a philosophical question, but there could be data here that would be useful. And if you have insight on data on this question, I would be interested in hearing it. I guess it's a question about when we think about privacy and protection of these personal health information or personal information more generally, I guess is how the EU system is set up. What are we protecting from? And are you aware of sort of a lot of cases where information has been, I mean, how did we get to a point where we are now highly protected and without sort of, to my knowledge, sort of huge seminal cases that involve these breaches that, I know they're breaches, but breaches that lead to what? And I would, from a health perspective, from a health data perspective, what are we worried about? And is this sort of goes back to my first question of, are we reacting in a way that really makes it hard for certain types of research to happen? And is the cost-benefit analysis, when we do that sort of analysis, are we doing the right kind of balancing to come out with the right output? So those are sort of a lot of different questions I think I have.
So that we can do this kind of succinctly.
Yes.
Let's take that first one.
So I'll start with the first one you asked, especially about the EU. Indeed, I think not only EU, as in researchers in Europe, actually recognize that this is a needed thing, because I think this is probably the same in both America and in Europe. What was also recognized is that this is a value for the European Commission and for the European Union. So actually, as we have the reform on the regulation on the data protection, there are some important provisions on something which is called data portability. So suddenly there is a shift from only protecting the data as in from third person, but also recognizing that this data is valuable also for the individual, and that she may choose, okay, not only don't I want that you process my data, I want to take it away and take it somewhere else. So the basic idea, for example, I would like to take my health data from, let's say, a hospital and give it somewhere else. And actually, there are legal means now in play, not yet active, but they are being thought about, to give this possibility to the individual so that he may, if he chooses, actually request that that person holds data, to just take them away. The second question is very...
Let me take the other two, I guess. Talking about consent, I think people do need to consent, and if by e-consent you mean that they get to indicate their consent on an electronic device, I certainly think that should be done. I think consent should be easy, simple, straightforward, and not require 130-page forms. And we have to do work on that both in practical terms and, of course, legal terms. In terms of what are we protecting against, I would say two things. First, maybe you missed the first talk this morning, which is the story of tremendous harm from a breach, but I would just refer you to Deb Peel's website, where she has hundreds of stories of people whose lives have been devastated by breaches. But even if that were not the case, I think we know from opinion surveys like Alan Weston's for the IOM, which showed that less than 1% of people in the U.S. were comfortable sharing their data for research without consent, whereas over 80% were comfortable sharing it if they were just asked. And so if you create a system with transparency or without that takes data without consent for research, I think that on the basis, justifying it on the basis of the tremendous benefits, I think you're risking a backlash from the population because the people in general believe that they should be asked about the use of their data. And so if you don't do that, I think you're likely to get a backlash, and then the use of data for research may end up being prohibited or severely restricted, and none of us want that. So I think from a practical point of view, you have to protect health data. That's people's expectation, and if you don't do it, it's a tremendous political risk.
If I may just add on this, for us in Europe actually framing the questions a little bit different, because I think we speak here about harm. We look at it in a more general view. Actually, both privacy and now also data protection, according to the Charter of European Union, is actually a human right. And as such, you don't ask well, is it very bad if you break this human right of yours because it's not very important? You simply say, okay, those are your human rights. We have to follow them. And there is no question, is it very bad, a little bad? You know, you have to acknowledge them in some way. Of course, you will balance the right to research against the right to data protection, but you have to acknowledge that those have to be respected in some way.
Yeah, it's the I guess I didn't totally phrase it exactly the way I meant to, but it was the connection between, I think as you spoke to this idea of depersonalization and the first question about the sort of barriers we put in place to accessing data has made it very difficult for there to be communication between doctors and patients about their own health information and between researchers and patients about their own health information. So, so I suppose the question I think that I wanted to ask was, how do we repersonalize healthcare health research while sort of being mindful of the risks that are there?
Absolutely.
Other questions? Yes.
Just very quickly, on the health banks, is the system you described up and running anywhere? And while I can see where that would help, the patient has some control over where his or her data is used for research, can that be used for actual clinical care as well?
Yes.
HIPAA exemptions for treatment, payment, and operation or so on?
So health record banks have been built in a number of places. Bellingham, Washington had one, although it's now shut down. There are a number of them operating in Europe. Rotterdam started one, and there's actually one in, there's the Lower Saxony Bank of Health. I don't know if you guys know about that, but I could connect you with those people.
That would be lovely. Really.
And they're actually working on this in Switzerland as well. They call them health data cooperatives there, and that was referenced. And the intent is, yes, these are essentially for use primarily for clinical use. In other words, all your records from all sources would be sitting in the health record bank, and you would make it available to your clinical providers for clinical care. And one of the obligations of the health record bank is to maintain the provenance of all the information, so that while you have the right to access it and decide who gets to see it, if you change, you may even have the right to change the information, but if you do, then the provenance is you, the patient. So when the providers see a lab result and it's from the lab, they know that that is really a good result.
Sir, I think you had one.
Yeah, there seems to be a misconception here that all research is therapeutic in its nature and likely outcome, when in fact most research is not even therapeutic in intent. Most research is a lot more than clinical trials. Clinical trials are not always therapeutic in intent. And then we have a more difficult situation I've encountered on IRBs, ethics review boards, and both as a member and as a chair. And this is for both universities and government. And that's attached to a great deal of medical research in this country is social and behavioral research. Much of it highly intrusive, much of it asking for great details as well as biosamples on families, asking about family violence, asking about encounters with law enforcement and so forth. And this is not just for social research agencies. The National Institute of Child Health and Human Development engages in this, as do many other agencies. Among the United States agencies, only one has criminal penalties for the sharing, for the wrongful disclosure of research data, and that's the Department of Justice for research that it sponsors. For everybody else, it's a free pass. This is not a healthy situation. It is not conducive to earning the public trust.
Absolutely agreed here. Also in Europe, I think the good thing about clinical trials is that they are actually the most regulated part of research, which is good because, of course, there's additional protections, which is bad because they are supposedly also over-regulated, which may be a problem. But you are right that other parts of research, the observational research, often is also completely terra incognita, which may be seen as a problem.
I want to keep you all on time to the next session here. Thanks so much for coming.
Thank you.
And thank our panel.